Hello everyone, welcome to today's webinar on the ISMP Medication Safety Self-Assessment for Perioperative Settings, how to obtain the most valuable, accurate, and useful results. I'm Judy Smetzer, a nurse and vice president at ISMP, and I'll be moderating today's webinar. As many of you know, ISMP recently launched this important self-assessment safety tool, which was funded by the U.S. Food and Drug Administration. Hospitals, freestanding ambulatory surgery centers, and other facilities that perform outpatient medical and/or surgical procedures will greatly benefit from participating in the assessment. This medication safety self-assessment tool is one of several that ISMP has created over the years. For this self-assessment tool, organizations are invited to evaluate their level of implementation for a little more than 200 best practices, all of which relate to safe medication practices in the perioperative setting. If you complete the self-assessment and submit your findings anonymously to ISMP, you'll receive weighted scores and be able to compare yourself to demographically similar organizations. Importantly, you'll also be able to detect areas of weakness and take steps to improve perioperative medication safety. During today's webinar, we want to provide you with a little bit more information about the tool and specifically invite your organization to participate. Next slide. We have two speakers today, Susan Paparella and Rebecca Lamis. We call her Becky. Susan Paparella is a registered nurse and a vice president at ISMP. She first joined ISMP in 2000. She's co-led several national safety summits resulting in the creation and revision of several ISMP safe practice guideline documents. She's often participated in consulting engagements and in large group collaboratives to advance medication safety. Becky Lamis is a pharmacist and a medication safety analyst at ISMP, first joining in 2009. She coordinates all of our ISMP fellowship programs and is the primary safety expert in the Medication Safety Board, a wholly owned subsidiary of ISMP and a leading authority to assist the pharmaceutical industry in ensuring the safe use of medications by reviewing the packaging and labeling. Both Susan and Becky have been key contributors to the ISMP Medication Safety Self-Assessment for Perioperative Settings. They helped an ISMP professional team and an external advisory group of perioperative experts create the tool. Becky has also overseen the building of the online assessment form used by participants to submit their findings. Both will be part of the ISMP team analyzing the findings from this assessment. Next slide. I just want to mention that neither speaker nor I have any conflicts of interest to disclose. Next slide. So our objectives for today's webinar include the following. First, we'll begin by stating how participation in the assessment will benefit healthcare organizations. Next, we'll outline the steps recommended for full engagement in the assessment process to ensure the most useful results. And then third, we'll describe how to complete the assessment, submit your results to ISMP, and use all the available reports to guide improvements. So let's get started. Sue?
Great, thank you, Judy. Next slide, Dan. Thank you. So hello, everyone. Just to get started here, as you know, we are a nonprofit organization with the mission to prevent medication errors. And as part of this work, ISMP provides a number of free tools and educational resources on our website. The ISMP medication safety self-assessments are available for various healthcare settings and can be used proactively to assess practices and processes and help to identify safety risks that may be latent within your current systems. Each are designed to be completed by interdisciplinary teams that include frontline staff, professionals and technicians, as well as management and leadership staff. Organizations have told us that the process of using this assessment helps to drive critical and honest conversation and discussion around current safety issues and really can be the first step in creating an actual plan for improvement. In the past, between 800 and 1,300 organizations have participated in these assessments, and some have completed them actually more than once in order to evaluate and monitor their medication-related improvements over time. So whether you're very familiar with ISMP and our assessment tools or are new to the process, we are excited that you have joined us today to learn more about what this new assessment tool can bring, and look forward to a time in the future when we can share the aggregates of results with you. Next slide, please. So why do we want to focus on perioperative services? We know that there's harmful medication errors that continue to be a significant public health problem, and according to WHO, result in at least one death every day and injure about 1.3 million people annually. In the perioperative setting, medication errors occur frequently in all phases of care, so think pre-op, intra-op, and post-operative phases, and are a common cause of morbidity and mortality. Although surgery is often considered a single event, a patient is moving through the entire perioperative care system during the surgical process, which consists of several different departments, teams, and medication procedures. And when medication errors occur, they're often the result of the complexity of the care that's combined with the fast pace and fragmented nature of perioperative service delivery. The frequency of medication errors reported in perioperative services varies widely depending on the detection and measurement strategies that are used. So in some studies report frequencies that range from one medication error in half of all surgical procedures when using an observational technique and a record review to detect and identify these errors, to one error in every 1,285 procedures when relying only on self-reported medication errors. In one of the studies, a few large hospitals that used barcode scanning and audiovisual feedback to verify the drug prior to administration in the OR found as many as one error in every 20 medication administrations, with more than a third of these errors leading to patient harm. And lastly, in one study, medication errors were estimated to occur in at least one out of every 133 doses administered during anesthesia alone. In preoperative settings, antibiotics are the most frequent medication involved in these errors. Knowledge deficits, unclear or misunderstood preoperative medication instructions, and errors in transcription of home medications are some of the most common contributing factors. In the intraoperative locations, such as the OR, analgesics, antibiotics, muscle relaxants, and vasopressors are most often involved in errors. In particular, fentanyl, propofol, and phenylephrine were noted to have the greatest incidence of error in one study. Wrong drug errors are often due to substitution or syringe swaps, incorrect doses, omissions, and wrong route errors, and they can account for up to 70% of all medication error types that occur in these intraoperative locations. And then in the postoperative locations, antibiotics, anticoagulants, and most commonly associated with these types of errors. And anecdotally, at ISMP, we hear from providers that suggest to us the safety practices are different in the perioperative setting than the rest of the organization. And importantly, we're often unable to learn a whole lot about these issues, as this area can be often underrepresented in the organizational event reporting systems. Next slide, please. So why should the organization choose to participate in this assessment? What are the benefits? Well, we feel the benefits really are twofold. They're at the local level and also at a national level. On a local level, we believe the participation will help to provide a standard way for organizations to assess the safety of their systems and practices in the perioperative care setting. And just in the process of doing the assessment will heighten awareness of best practices. And then getting results, you can compare your results with those demographically similar organizations, whether you're in an inpatient setting or an ambulatory care setting. And then also you'll be able to create your organization-specific safety-focused initiatives for the improvement of care within that setting. Next slide, please. So the benefits on the national level, we hope the assessment will create for the first time on a national scale a measured baseline of current hospital and ambulatory surgical center efforts to enhance the safe use of perioperative medications. Specifically, the aggregate assessment results will help to identify any national vulnerabilities related to perioperative medication use, can help to determine specific challenges that are faced only in the perioperative setting, and ultimately allow for the development of additional resources based on the results that can be employed again in hospitals and ambulatory centers to prevent these harmful medication errors. Next slide, please. The assessment tool was completed following a review of ISMP's Medication Errors Reporting Program, or the MERC data, an extensive review of professional standards and also the literature, and with the support of an expert advisory group made up of dedicated perioperative practitioners. These leaders in perioperative services help to ensure that the systems and practices most critical to the perioperative medication safety venue were included as assessment items, and the expected practices were achievable in many types of healthcare facilities. We want to take a moment to thank these practitioners who offered their time and talents over many months of Zoom calls and late night content reviews and emails to help us get to this final product. I would also like to take a moment to reflect as very sadly 2 members of our advisory group, Ann Shimmick and ISMP's medical director, Ronald Littman, have passed away since helping to inform the content of this tool. Their contributions to this project will have a profound impact on perioperative medication safety and thus will not be forgotten. Next slide, please. We also wish to acknowledge the organizations listed above who, along with ISMP, have a fundamental belief in the power of collaborative efforts for the benefit of patient safety and who have endorsed this tool for use in the industry. We thank them too for their continued collaboration and support. You will find their logos when you view the back page of the PDF workbook. Next slide. So you may ask yourself, how does this apply to me? Am I eligible to participate? Well, so certainly and broadly, the tool was developed to be very inclusive of all U.S. hospitals that perform inpatient and/or outpatient medical and surgical procedures. It's for freestanding U.S. ambulatory surgery centers, including those who are dedicated to specialty procedures such as GI and endoscopy procedures, and other U.S. facilities that perform outpatient medical and surgical procedures. But more specifically, on the next slide, this scope includes perioperative and procedural processes, staff, equipment, technology, environment of care, and/or medications that are associated with the medical and/or surgical procedures and the patients who undergo them. For the purpose of this assessment, a medical or surgical procedure is defined as any procedure performed in a patient by a licensed healthcare practitioner that requires moderate sedation, deep sedation, monitored anesthesia care or MAC, regional anesthesia, and/or general anesthesia, including those diagnostic and invasive procedures that meet this definition. So there's just a few things that are excluded from this assessment, and those are procedures that require minimal sedation, defined as a drug-induced state that does not affect the patient's airway, reflexes, ventilation, and cardiovascular functions, or their ability to respond to verbal commands. Also excluded from this assessment is the care of patients after they are discharged from the facility or transferred from the perioperative setting, usually to an inpatient hospital bed. Next slide, please. The assessment items contained in this tool were selected based on the types of errors and safety risks identified in the perioperative setting, and specifically those that address critical safe medication systems and practices. Both evidence-based and consensus-based opinion items provided context. The items extend really beyond the minimum standards of practice, beyond regulatory requirements, and instead really help to determine if organizations have implemented what is understood in the healthcare community to be best practice. Next slide, please. So let's quickly take a look at what you can find as you access some of our materials. This is an image of the table of contents that you'll find in the PDF workbook. This includes many of the typical sections in a tool such as this, key definitions, frequently asked questions, and instructions on how to create your team and to get the project underway. At the start, each organization will be asked to complete questions in the demographic profile. This again, as Judy mentioned, is an anonymous data collection. Demographic questions are not designed to identify sites, but to help sort responses into meaningful groups that will help during the evaluation and comparison of the aggregate results. The assessment itself contains 221 items divided into 10 key elements of the medication use system, which is ISMP's conceptual model, and they can be found here on the image in the blue section. Each element contains one or more subdivision or themes that are known to us as core characteristics, and there's 19 of them. And if you've done an ISMP assessment previously, you will definitely recognize this format. Becky will be going over the demographics as well as the key elements and their related example items in just a few moments. Next item, please. Within the body of the assessment questions, you'll see a number of commonly used key terms. Words such as caregiver, perioperative, high alert medications. We felt it was important to define for clarity. So if you're using the online form, these appear in the right-hand side of the tool in toolbar for easy visibility and access. If instead you're using the printed workbook or the PDF, these key definitions appear at the beginning on page 8 before the demographic questions and assessment items. Additional defined terms that are also important but are less common can be found in the glossary. And the glossary can be found either on pages 73 to 78, and they're designated throughout the text in bold, small, capital letters, as you can see described on this slide. If you happen to come across one of these in the online version of the assessment, these glossary terms will appear and they'll be linked to their definitions. So you can access the definitions by actually just hovering over the term, as you see here in this image. Next slide, please. Although a total score is provided once you've completed the entire assessment, the purpose is really not to think of this as a test with one perfect score. The final score is not the most important metric, as all organizations are on their own journey to impact medication safety. And while we hope your efforts will result in a great score, we want this to be an opportunity to assist in the identification of safety gaps so your organization will have a starting point, be able to set priorities, to work directly on those lower scoring items for improvement over time. As you can see here by the blue arrow, the scale is from A to E, and again, it's a similar scale to it's been used in other assessments, and it ranges from having no activity for the implementation of this item to E, which stands for this item is fully implemented for all patients, orders, drugs, or staff. And while this focuses on instituting standard best practices, we also recognize there are significant differences in the types of care and the procedures provided by the different types of facilities. So this is also reflected in the scoring. For example, you might work in a facility that does not care for pediatric patients. So if the item is only for pediatric facilities, then there will be an option of recording not applicable. You may not do any organ harvesting. So for this type of question, you may also have an option of selecting not applicable. Each of these sort of items, with the exceptions, will provide a scoring guide within the item. So it will help you know if you need to answer the question or not. It's pretty self-explanatory when you see it. Next slide, please. Our scoring is built using a standard methodology to independently evaluate each item in the tool and apply a weighted score for the item and associated responses. So these scores are really based on the impact they have to patient safety and the ability for this item to really sustain improvement over time. So for example, the self-assessment items that have the greatest weight are those that target system design and redesign, those that do not rely heavily on human memory, performance and vigilance, that standard high-risk populations, that create system design barriers such as fail-safes and forcing functions, that help to simplify, standardize, and centralize those complex error-prone processes, and certainly reduce practitioner tolerance of risk and increase the incentives for making safe choices. And all of this is built within the ability to develop and sustain a just culture. So some of the assessment items are weighted in such a way that result in no numerical score or zero value unless there's partial or full implementation, which is choices C, D, or E of the item. However, a few of the items that require extensive planning have been assigned a weighted score for formally discussing the item, such as choice B. Some of the assessment items are weighted in a way that results in no numerical score unless there's full implementation of the item throughout the organization. Weighted scores also have been assigned to not applicable choices based on the degree of risk that's associated with not implementing that suggested error reduction strategy, for example, smart pump technology, or the degree of risk that's avoided by not treating a specific population, such as pediatrics. So if the risk does not exist, such as having no pediatrics, then the highest point value for that question may be attributed, while other types of not applicables, like not having the use of smart pumps, may not carry any score because of the absence of this known technology. Scores for questions and sections are not viewable during the active assessment, but they are only available after completion and submission of your data. Next slide, please. This is just an image of ISMP's rank order of error reduction strategies. It may be familiar to you, and it just as, again, another way to help explain our scoring approach for the weighted items. With this information, weighted scores were determined for each item ranging from 0 to 16 points. So if the assessment item reflects a best practice that's considered low leverage, that's least effective, and focuses mostly on human reliability, the maximum value, even if you answer E, may be 6 points. However, if you also answer E for an item where there's a high leverage risk reduction strategy, the maximum value of these equates to 16 points. Next slide, please. And then I just want to end by talking about frequently asked questions. They are used throughout the assessment to help further clarify a question or item and just providing guidance for allowing you to give an accurate response. In the top of this slide here, the photo on the right is a screenshot of the online form, which in question number 4 has an FAQ symbol at the end of the sentence, you'll notice there. And it will help you, if you click on it, it'll open a new tab and take you directly to the FAQ. There's also a link in the upper right-hand corner of the online form, which is not shown here in the slide, but you can access all of the FAQs from that point as well. The bottom photo on the right is a screenshot of item number 4 in the PDF workbook to show you what that looks like in the document if there was an associated FAQ. So it does not obviously link directly to the FAQ, but you would have to go to the FAQ PDF, which is a separate document that's also available on the same web page as the rest of the materials. And when you open that document, you just look for the explanation associated with the assigned number. So in this case, FAQ number 4. It will be very useful to your team to review the associated FAQs both before and during the assessment to help you answer the questions most accurately. And I would suggest that you have them readily available as you go through the assessment. So now, at this time, it's my pleasure to pass the program over to my colleague, Becky, to introduce you to the types of items in the assessment and the mechanics of completing the online process.
Thank you, Sue. Good morning or good afternoon, everyone. As Sue mentioned, there is a demographic component to this assessment with 2 sets of demographic questions, depending on if you're a hospital, which has 20 questions, or if you're a freestanding ambulatory facility, which has 19 questions. These demographic questions include questions about your facility, like your bed size or number of patient visits, your location, questions about the number and types of procedures that are performed. And for hospitals, that would include both inpatient and outpatient procedures, as well as questions about your anesthesia services and technology that's available for use. Next slide. As Sue presented, the Assessment items are structured based on ISMP's 10 key elements of the medication use system. And within each of these keys, there, again, as she mentioned, there are one or more core characteristics, which are subsections within those key elements. So key element 1 is all around the need for essential patient information to be obtained and readily available to healthcare practitioners caring for perioperative patients. It only has one core and 25 items, which cover topics such as medication reconciliation, allergy documentation and screening, and required monitoring depending on the phase of care and/or medications administered. Key element 1 also includes items related to patient weight, such as item number 11, which states that on the day of the procedure, patient weights measured in only metric units are obtained for all patients. Next slide. The next key element, key 2, also only has one core and 18 items and is focused on the need for essential drug information to be readily available to perioperative healthcare practitioners. The items covered in this section of the assessment deal with having maximum dose limits and ranges established for various drug therapies, how orders are entered into the system for electronic screening, having emergency drug dosing guidelines easily accessible during a code, and the use of preference cards. There are also other items included in this key that relate to having certain protocols in place or having additional important drug information readily available to practitioners where needed, such as with item number 38, which states that a protocol for treating malignant hyperthermia based on current in-house reference material is readily accessible. Next slide. Key 3, which also only has one core, addresses how orders and other drug information are communicated, including items about communication between practitioners during a procedure, the development and use of various protocols, guidelines, and order sets, and other communication issues such as verbal orders, as in item number 49, which states that face-to-face verbal orders from prescribers who are on site are never accepted in emergencies or during sterile procedures, except in emergencies or during sterile procedures where ungloving would be impractical. Key element 3 has 21 items. However, some of these items do have subparts that are all answered separately. So some of the items that ask about if a certain order set has been established, they do include some multiple subparts that are each answered individually to measure implementation with each of those components. Next slide. Key element 4 has 22 items split into two core characteristics. One that focuses more on reducing errors related to products with similar names and/or labeling and packaging, and the other that relates to having clear and readable labels on drug containers. So the types of topics covered include strategies for differentiating or separating lookalike products, how to safely store medications in the perioperative setting, using pre-printed labels and labeling drug storage areas and containers. And it also includes items that address specific products that could be mixed up with other drug products, such as in item 71, which states that vials of tranexamic acid are sequestered or separated from lookalike vials used for regional anesthesia, like bupivacaine or ropivacaine, which have been mixed up due to the lookalike nature of some of these vials, resulting in the accidental intraspinal injection of tranexamic acid. The next key element, key 5, has 4 core characteristics and has the most items of all of the keys, with 47 items, and also with some of those items having subparts that each need to be answered individually. These 4 cores cover using standard drug concentrations and mixtures in commercially manufactured or prepared or pharmacy prepared products, stocking medications in the perioperative setting in a safe and secure manner, restricting or limiting access to certain medications, and safely preparing, storing, and/or administering hazardous drugs and chemicals. One of the items in core 8 related to restricting access is item number 126, which aligns with one of ISMP's targeted medication safety best practices and states that fentanyl patches are not stocked in perioperative unit stock and are not used to treat acute or postoperative pain. Key element 6 only has one core with 16 items, although a few of these items do again have subparts that are each answered individually. Items related to the procurement, maintenance, use, and standardization of medication delivery devices include using standardized infusion pumps, using smart pumps with drug libraries that have set limits, such as item number 140, that calls for upper and lower hard limits to be set. Other items address processes around the administration of bolus and loading doses, the use of in-fit and oral syringes and in-or-fit connectors, and also utilizing smart pump data for improvement purposes. Key element 7 has 2 cores, but it's one of the smaller keys with only 11 items. And again, with a few of those having subparts that are answered individually. These 2 cores relate to the setting, workflow, and physical environment in which practitioners work, and then also address the need for a complement of practitioners that matches the workload without compromising safety, such as in item number 158 that states that an adjusted caseload, delay in procedures, or planned late arrival of a practitioner due to fatigue from working on call or overtime does not result in punitive action. Key element 8 on staff competency and education also has 2 cores and only 11 items, but no subparts. This section includes items related to ensuring that perioperative practitioners are qualified and have the training to perform certain tasks, as well as that the staff receive ongoing education about error prevention and associated strategies. Item number 162 is one of the items in this key and states that role-playing and simulations of perioperative error-prone conditions are used to orient and educate staff about safety. Key 9, patient education, along with the 2 prior keys, is one of the smallest sections with only 1 core and 8 items, again with some of these items having multiple subparts. This key contains several items about educating the patient or their caregiver about the medications that they're receiving, including during the different phases of care, at discharge, and for specific therapies such as patient-controlled analgesia, as in item 174, which addresses the need to educate patients and caregivers about the dangers of anyone other than the patient activating the PCA button and labeling the cord or activation button with this warning. Finally, the last key, key 10, on quality processes and risk management, has 4 core characteristics and is the largest key, second largest key only to key 5. The 4 cores in this key cover items related to just culture, reporting errors and hazards, and analyzing these reports, as well as reviewing external error reports to mitigate future risks, using redundancies such as independent double checks and barcoding to detect errors before they reach patients, and lastly, following infection control practices, such as with item number 220, which indicates that a bag or bottle of an IV solution or medication is never prepared and or used outside a pharmacy as a source for multiple flushes, diluents, or bolus doses for one or multiple patients. So now that we've gone through the types of topics and items that you'll find in the assessment, for the remainder of the presentation, I want to walk you through how to access all the materials that you'll need and the steps for conducting the assessment. All of the components of the assessment can be accessed from our website at www.ismp.org. You will either see the link to the perioperative webpage directly on our homepage, as you do now, or you can also go to the Tools and Resources tab, and then you can click on the perioperative settings link under self-assessments. So on the web page for the perioperative assessment, which you can see a screenshot of that on the right, you can access the online self-assessment form. which is where you'll need to submit your responses to ISMP, as well as the frequently asked questions, instructions, key definitions and glossary, the full assessment PDF, or it's also called the workbook, and then also the Excel spreadsheet, which contains the demographic questions and assessment items. So to access the full assessment PDF or workbook and the Excel spreadsheet, you will need to be logged in to your account for the main ISMP website. Please note though that this account and login is different from the login that will be created to submit your responses to ISMP. So if you don't already have an account for the main ISMP website, you can create one for free. And through this account, you'll also be able to access other freely available resources on the ISMP website. So to access the full PDF and the Excel spreadsheet, you'll scroll down to the bottom of the Perioperative Assessment webpage. And if you are not logged in or don't have an account, this is what you will see. It says access this free resource. And at that point, you can either sign into your account or you can create an account and go to register now. Once you are signed into your account, you should see these two yellow buttons at the bottom where you can download both of those documents. So again, just as a reminder, for this account, multiple individuals from your facility could create their own account to access these documents. However, for the online assessment form where your facility is going to be submitting its responses, that should just be one individual from your facility. And again, those two logins, those two accounts are separate. So the full self-assessment PDF or workbook includes basically everything that you need as far as goes from the invitation to participate, the purpose and scope statements, the listing of our advisory group and endorsing organizations that Sue went over, the definitions, the complete instructions for conducting the assessment, the demographic questions, and the assessment items. So this can be used to review all of the information and demographic questions and items, and it can also be used to complete the assessment if your facility would prefer to print the PDF and complete it on paper before entering and submitting through the online form. We do, again, also offer an Excel spreadsheet of just the demographic questions and self-assessment items. We would recommend considering using this or the PDF to complete the assessment first and collect your responses, and then use the online form as I'll walk you through. But the online form does require that you complete and submit the demographic questions before you can go on to the items, and it also requires you to complete and submit one core characteristic at a time. So the Excel file can be used to can be a bit easier to review and revise any of your responses before you actually do enter and submit them through the online submission form. Can also be used to more easily distribute items to team members as needed. It also has a column for documentation of any discussion that you may have around your selected assessment choices, which can be helpful, as well as columns that you can sort and review the responses that you've selected for each of the items. So as I mentioned, the online self-assessment site or form is where only one individual from your facility should create an account, and it's where you'll be submitting your information anonymously to ISMP. So no matter how you choose to initially complete the assessment, whether that's using the PDF, the Excel file, or you want to use the online self-assessment form itself to complete it, you will need to still use this to enter and submit your information to ISMP. So through the online site or form, you can reset your password automatically if you provided an email address during account creation. You can save and return to your entered information at any point. So it does not need to be completed and submitted in one sitting. And after submitting the entire assessment, you will be able to view your results. This is also where participating facilities that submitted the entire assessment will be able to access the aggregate data once that's available in the beginning of the fourth quarter to compare themselves to demographically similar organizations. So to access the online site or form, if you're on the web page for the perioperative assessment, as we walked through a few slides earlier about how to get there, you will find a link under Related where it says log into self-assessment site. So that takes you to the site where you can create your account to enter and submit your information. There's also links under Related if you just for the frequently asked questions. And then also if you just want the instructions and key definitions and glossary, you can get to those from there as well. So as far as the process for conducting the assessment, the first step is for each facility. So first, each facility within a health system should be completing this individually. So even if you have standardized some policies and practices across your health system, it really, each individual facility should be completing this separately. As we know, some actual practices may differ or vary from facility to facility. And then, like with all of our other assessment tools, the first step is for each facility then to establish an interdisciplinary team that's going to work as a group to complete the assessment items. So as medication use is a complex and interdisciplinary process, the self-assessment, which encompasses the entire medication use process, shouldn't be completed by just one discipline. And the value and accuracy of completing the assessment is actually greatly reduced if only one discipline completes it, as the items do require input from multiple disciplines. Not only does completing the assessment as an interdisciplinary team provide your organization with a much more accurate picture of what practices is actually like, we think that completing the assessment together can lead to insightful discussions around practitioners that certain team members may otherwise be unaware are occurring or not occurring. So the core team members that are recommended for inclusion are listed on this slide, and you can also find them listed in the full PDF or workbook of the assessment within the instructions. And it includes a combination of senior leadership and frontline staff, again, from all disciplines that are applicable to your healthcare setting. There does need to be a combination of both leadership and frontline staff, as there may be practices that are occurring that leadership may not be aware of, that only frontline staff would be able to speak to. And also having leadership involved is important to send a message about the facility's commitment to making medication safety improvements. It should also be established up front with this group that during the assessment process, all individuals are to be as open as honest as possible, and that everyone should feel comfortable speaking up regarding the practices that they see occurring. You may also need to include additional members outside of your core team to help answer certain items as needed. So then the next few steps in the process, first you would, from your core team, want to choose a team leader or leaders who will be responsible for keeping the meetings on track and compiling and submitting your facility's responses, as well as an individual to record any discussion and your responses that you've selected. You will want to then provide your team members with access to all of the components of the assessment so that they can review them ahead of the meetings. And your team will need to decide how you plan to complete the assessment. So whether that is, again, by printing the PDF of the assessment and writing down your team's responses, utilizing an Excel file, or entering your group's responses into the online assessment form as you go along during your team meetings. Again, no matter which option is selected, in order to submit to ISMP, you will still need to enter your responses into the online form. So the team leader may want to or need to verify some of the demographic information with others outside of the first team meeting. But during your first team meeting, that's when you could need to complete the demographic questions and review the assessment process. Again, prior to and during all of your team meetings, we would suggest providing team members with a copy of the items that are being discussed. Your core team would then meet to complete the assessment items, along with any additional team members who you've selected to be on your team as needed. And based on pilot testing of the assessment, it was estimated that may take around 3 to 4 1.5-hour team meetings to complete. So you want to start planning those meetings and scheduling them out to make sure you can meet the deadline. However, certainly it might take, for some facilities, may take a little longer depending on the amount of discussion that you have around the various items. So just even knowing that there are over 220 items, thinking about 1 minute or 2 minutes each, how long that might take you. Likely after your first or second meeting, you'll probably get a better feel for your progress that you're making and how much time it's going to take you to complete the entire assessment. So when discussing and choosing the answer of A through E are not applicable for each item that your team evaluates, you may want to record any discussion generated around each self-assessment item and the rationale behind that selected choice. This can provide insight into why the choice was selected for that item at that point in time, and it might be helpful to your facility as you move forward with implementing improvements. One other important point is that the assessment of each item should be based on what actually occurs, not what can be found in current policies or what ought to occur. Completing this assessment shouldn't be viewed as a test, as Sue said earlier, but is instead meant to assist facilities in uncovering opportunities for improvement. So although some self-assessment items do specifically ask about certain policies or procedures that are in place, the items also suggest evaluating whether these are actually followed. The most value from this assessment comes when teams consider what the actual practice is, not what a policy says that it should be. That way, system-based improvements can be implemented and you can address the real vulnerabilities that exist within your facility. So finally, once you've completed the assessment, you'll want to make sure you submit your information to ISMP by August 31st, again, using the online submission form. So for the next few slides, I'll walk you through the process for using the online form, where you'll need to, again, enter and submit your information to ISMP. As I mentioned previously, only one individual from your facility should create an account for the online assessment site or form, which you can get to from the ISMP Perioperative webpage. So once you're on the online assessment site or form, which you see on your screen, you will click in the upper right corner. There are links for you to create an account if you don't have one yet, or to log into your account once you've created one. So if you haven't created an account yet, the individual who creates the account for your facility will be required to create a username as well as password. And then there's also the option to enter an email address. This is not a required field, but it does allow you to reset your password through the online form, and it's really the only way that we could retrieve your account if you forgot your username and password, because we aren't asking for identifiable information in the demographic section, such as hospital name. That's not something that's being asked. So really, if you forget your username and password, the email address would be the only way we could retrieve that for you. As part of the account creation, there's also an option to enter a collaborative code if you're part of a collaborative group that's working with ISMP to aggregate your group's data. And I'll discuss this opportunity a little bit more in a few slides. There's also a required field to select your facility type. So whether hospital, freestanding, ambulatory surgery center, or other outpatient facility. And then this is used to direct you to the correct set of demographic questions. So after you've created your account, there are going to be a few introductory pages that you'll need to click through to get to the demographic questions. And then once your facility has submitted the demographic questions, you will be able to move on to the assessment items. Please note, though, that once you submit your responses for the demographic questions, you will not be able to make any changes to that section. So you want to make sure that you have everything entered as you want it to be before you go ahead and submit. You will then be directed to the self-assessment items, which you'll complete one item and one core characteristic at a time. When you're working within a single core characteristic, you can make any changes that you need to within that core, but once you do submit that core, you won't be able to make any changes. And then you will be move on to the next core characteristic. For both the demographic questions and assessment items, At any point, you can log out and we'll be able to return to your assessment by logging back in again. Please remember though, if you're in the demographic questions, make sure you hit the Save Draft button, or if you're in the self-assessment items, there's a button that says Save and Continue. So make sure that you are saving as you go along. Otherwise, if you do log out, your information won't be saved. But if you have hit the Save buttons and you log out, you will be able to log back and it will take you back to where you left off. Once you've submitted the last core characteristic, so core 19, you will be directed to your facility scores and submitted responses. The results that you'll receive include your facility's weighted score, the maximum weighted or possible score, and your facility score as a % of the maximum weighted score for the entire assessment, and for each key element and core characteristic. With your scores, listed with your scores for each core, will also be a link that says view your answers. And that's where you can view your answer choice, weighted score, and the maximum weighted score for each item in that core. At any point after submitting, you can log into your account to view your results. And then also, at this point, you can also have the opportunity to view how your facility answered the demographic questions. So this is an example of the report that you would see when you click on the link to view your answers for a core. At the top, you will see your total score for that core, the total maximum number of points possible, and then your score as a %. So in this case, there are 128 possible points for core 1. This facility received only 40 points, which resulted in a % score of 31%. You'll also see a green check mark next to the answer that your facility selected for each item. So in this case, it was choice of A. And then also you will see the score that your facility received for choosing that answer and the maximum number of points for that item if a choice of E had been selected. So in this case, the facility received 0 points for that choice of A out of a possible of 4 points. So as I mentioned, during account creation, you can enter a collaborative code if you're working with ISMP as a collaborative group. So if there are any health systems or healthcare or other hospital associations, ambulatory surgery groups, purchasing organizations that are interested in contracting, working with ISMP to do this for your collaborative group, we are offering this opportunity for, there is a fee associated with this, but we will work with you to aggregate your group's data through the use of these collaborative specific codes. Facilities, as we walk through, you can enter your collaborative code during account creation, or there's also the possibility of you entering it into your account after submitting the entire assessment. Following the submission deadline, then ISMP will provide each collaborative group with an Excel spreadsheet of their aggregate data. And if you are interested in more information, including pricing information, please feel free to contact us at selfassess@ismp.org. And finally, I believe we will have time for some questions now shortly here during the webinar. But if you do have any questions at any point throughout the assessment process, including IT issues or just the questions about the assessment itself, please feel free to contact us. There's several ways to do that. You can email us at selfassess@ismp.org. You can submit a question using the Contact Us link on the ISMP website. You choose the self-assessment drop-down choice. Or if you're in the online form, there's a Need Help link in the top right corner that you can click on and also submit a question. So now I'll turn it back over to Judy and see if we have any questions.
We do. We have quite a few in both the chat and the questions and answer form. So let me ask you the first question, which a number of people have asked here. For organizations part of a larger health system, would you recommend each hospital facility complete this individually, or should we complete as a system and score for the lowest value possible? And then there were additional questions that related to the similar questions that were asked about if you're a 2-hospital system, is there expectation that each should be doing it separately? Sue or Becky, do you want to answer those questions?
Sure, I can start, Sue. So we do recommend that each individual facility complete the assessment. There is actually an FAQ about this, very top if you want to also refer to that. But even in a health system that has standardized some of their policies and some practices, we do still find that, you know, between those facilities, there is still differences in actual practice and what might be occurring. So we do recommend that they are still completed separately so you can assess the risks from within each of those individual facilities. And I don't know, Sue, if you want to have anything you want to add to that.
No, I think that's exactly what I would say, Becky.
Yeah, so for an accurate assessment, we highly recommend that each individual facility conduct their own assessment. If you want to get information as a collaborative group, as a hospital setting group for a health system, you can work with us and get a code to sort that information and get it collaboratively. Okay, on to the next question. One person asks how long it might take to complete the assessment. And I did answer this one individually in the chat to say that during pilot testing, it took about 3 1.5-hour meetings of teams for the ambulatory surgery settings, and those teams were usually 2 to 3 people, interdisciplinary people. It's important for each facility within a multi-facility system to complete the assessment, but it's also important to have interdisciplinary teams conduct the assessment. And then for a hospital, pilot testing showed that it took about 4 1.5-hour meetings. And those teams usually were composed of 3 to 8 interdisciplinary team members. Anything you want to add to that?
I think that sounds great. Thanks, Judy.
Okay. So one person asked, or a number of people asked that they see the Joint Commission has endorsed the assessment. Does this mean that the Joint Commission requires organizations to conduct the self-assessment and or achieve a certain level of implementation for the assessment or individual best practices? And another person asked if you could further explain whether it's mandatory to complete the assessment or whether it's just a beneficial safety review.
I can take that, Becky. So no, completion of the assessment tool or the attainment of a particular score is not required by Joint Commission or any other accreditation organization. And however, you know, we can't speak for Joint Commission specifically, but we know that using assessment tools like this one, just like the ones in the past from ISMP, to help evaluate your organizational practices and identify those opportunities for improvement and demonstrating actions around those safety gaps, all support those elements of performance that are listed in several of the standards, whether it be for medication management in the Joint Commission or performance improvement. So we really do know that organizations have gotten accreditation value from doing this type of work.
I just have a follow-up question regarding the time for completion of the assessment. Our PDF document shows a time commitment of about 26 hours, and that's because we had to add each team member's time individually. So it's a cumulative total time represented in the PRA burden statement. So the Paperwork Reduction Act required us to take each of those hours and multiply it by the number of team members that were present at the meeting and just come up with a maximum number of hours. So 3 times 1.5 hour meetings times the number of people who were attending those meetings is how we came up with those total numbers. So the next question is, can the assessment narrow down the lower scores into different areas inside the facility to fine-tune implementations to the different areas? So I can answer this one and say that the assessment score, each best practice is answered based on the area that the best practice covers. And so it's a cumulative score, and it might not break it down or help you prioritize implementation in certain areas, in the different areas, but during the discussion, when you're coming up with a consensus agreement as to how you would evaluate your implementation of that best practice, that's where you can talk about the different areas where that best practice might be best served and where improvement might be needed. So,
Judy, I'm thinking of an example that there was a question too that came through about whether or not this particular assessment was applicable to OB, and certainly the surgical procedures that are performed in that type of setting. And certainly we would say yes, that they should be included. However, you may find while you're going through the assessment items that practices around a certain item may vary between what is considered your surgical suites and maybe the surgical area in OB. And so, that in itself is, one of the benefits of the tool is recognizing those variances. And you can take notes against that both in the PDF and on the Excel spreadsheet as you come up with your consensus answer, which may not be fully implemented. It may be partially implemented in some locations in some areas, but then you'll know as an organization from your notes then, what type of steps you might have to take then for total acceptance of that best practice.
So one additional question is, what I'm hearing is that there should be a collaborative group and not 2 different groups conducting the same assessment. So in other words, the OR shouldn't conduct the assessment and the pharmacy separately conduct the assessment. We're asking for teams to get together. We think that's the best way to conduct this self-assessment is to form these interdisciplinary teams, put the OR staff with the pharmacy staff and anesthesia staff and answer the questions or evaluate your level of implementation of each best practice as an interdisciplinary group. Because the pharmacy might think that something's being done that's not being done in the OR. The pharmacy might be sending medications a certain way that's then manipulated in the OR and not meeting their needs. And there's no better way to understand that process than to get people together, interdisciplinary people together in a room and really describe the differences. Well, it's 3:03, and so we're a little bit beyond our time. There are some additional questions, and what we thought we would do at the end of this webinar is answer all the questions that were asked in the question and answer, or even in the chat section, to do that individually or to put it online for everyone to get some value from answering the questions. So at this time, we will end this webinar and just say that we're excited and we hope that you will participate in this very valuable tool. And we hope to answer your questions as you go through the assessment. If you have any questions, don't be afraid to ask us, and we will help guide you through the assessment. Thank you, everyone.